Hello and welcome everybody to our Anselm exchange today. Thank you for joining us. My name is Travis Patel and I am the Associate Director of University Engagement at Anselm House. For those of you who aren't familiar, Anselm House is a Center for Christian Study and a Christian community at the University of Minnesota dedicated to connecting faith and knowledge with all of life at the university and beyond. We're really excited today for this conversation that we get to have about spiritual care and chaplaincy in extraordinary times. So just a few words by way of introduction. Many people have suggested that coronavirus and the current pandemic may cause people to ask questions about meaning and purpose and suffering in a particularly acute way in the coming months and weeks. In this way, the pandemic may be described as something of what our panelist Michael Balboni has talked about illness as a spiritual event. In our conversation today, we hope to delve into this idea of illness as a spiritual event, and then also the particular challenges of the coronavirus pandemic for spiritual care and chaplaincy. We want to talk about the role of chaplains and others in accompanying those who are suffering and those who are going through illness. And one thing to note is that spiritual care and chaplaincy is one context, especially in the medical context, where faith and knowledge do intersect in a particularly interesting way as people are trying to bring together empirical evidence about what brings solace and what brings health and healing and flourishing with questions about meaning and purpose and spiritual questions as well. So we want to bring those things together in this conversation. As always, for our Anselm exchanges, we invite your participation. There is a Q&A button at the bottom of your screen, and as we discuss over the first half of this conversation, I invite you to enter questions for our panelists there and direct them to the various panelists. You can choose to vote for the questions that you find helpful or interesting, and we'll try to do our best to get through as many of those as possible. So without further ado, I'm going to go ahead and introduce our panelists. Our first guest today is Michael Balboni. Michael is on faculty at Harvard University and is theologian in residence in the Department of Psychiatry at Brigham and Women's Hospital in Boston. His social science research has centered on the intersection of spirituality and medicine, and he also serves as a congregational minister at Park Street Church and the Longwood Christian Community. Thank you for joining us, Michael. We'll also be joined today by Kelly Ferguson. Kelly is an ordained chaplain with Converge, formerly the Baptist General Conference. She also serves as the Director of Spiritual Care at Lingblomston Care Center, a Christian nonprofit organization here in St. Paul, Minnesota, serving older adults and their families through healthcare, housing, and community-based services. Thank you for joining us, Kelly. Finally, we'll be joined by Paul Gauchet, who's a research chaplain at mHealth Fairview, connected with the University of Minnesota Medical Center. Paul has been a healthcare chaplain for over 15 years, which has included working as an inpatient palliative care chaplain for 10 years and serving as a bereavement coordinator. He also serves as the convener for the Hospice Palliative Spiritual Care Research Network, sponsored by Transforming Chaplaincy. Hello, Paul. So each of our guests has a lot of experience, but from different perspectives and different contexts. I'd be curious to ask just a basic question to introduce our topic today. And that question is, what is the role of a chaplain as you see it? How do you think about spiritual care in your context, and what, in particular, what good or adequate or maybe excellent spiritual care might mean? And how about we begin with you today, Paul?
I'm smiling because I think if you get a few chaplains in a room, this could take a couple hours. So I'll give my 2-minute best to this. So I think especially in these times, I think chaplains are healthcare workers. I think we're healers. And I think that we are specialized spiritual care folk. And the way that I would try to frame the work I get to do, especially in palliative care, is that we get to become a part of people's stories. especially when they're disrupted and disoriented. And thankfully, people let us become a part of their stories, which is where I think we hear things like emotions and meanings and values. We hear their struggles, how they're coping, and then how they're kind of making sense of all of that. And I think that's the grist for the mill that brings me to this work and gives me a lot of satisfaction for that. And I look forward to hearing what Michael and Kelly have to say for that as well.
That's great. How about you, Kelly? How would you answer what good spiritual care is, and what is the role of a chaplain?
Well, my context is with older adults, the people who are most vulnerable at this time with the epidemic. And so I just continue the relationships that I've built with people. I think it's important to bear witness to their stories and to provide comfort. I've increased my one-on-one visits with people. I have more time for that right now. This setting here, it's a Christian home, and I'm thankful that we do have Sunday worship services, although we can't meet together in the chapel, but we've put them on we have a channel within our different buildings, and people can watch those. So I think like last week was Holy Week, and so I see my role as a pastor as well to people who are Christians, who are believers. And we provided 4 services last week. There's another chaplain I work with, and we also now have a hymn sing, and they enjoy that. So through music and some of our services, we're still doing the things we're doing, but having to be more creative.
Mm-hmm. What about you, Michael?
Well, good spiritual care is caring for the souls of the people that are in front of you. I think that's the most obvious way of answering the question. They're embedded within that response, within all of our responses, are very deep assumptions of what it means to be human, what it means to have a soul, and how does that soul flourish. And there are very different ways of thinking about those questions and responding to them. So one can, as it was alluded to, I'm a congregational minister at an evangelical church in Boston, and spiritual care within that tradition is going to be very different than spiritual care from another religious tradition, such as the Buddhist tradition or the Islamic tradition, or even some other Christian traditions that do theology in a very different way. So spiritual care, at least in my view, ends up being mediated through different theological traditions of how you understand who God is, or what the divine is, how you understand what the human condition is, where authority lies as far as revelation, and kind of all these kind of deep theological questions play themselves out. And I'm a congregational minister. I'm not actually a chaplain in a hospital, so I have a very different perspective. And I think from a congregational pastoral perspective, spiritual care looks very differently than how chaplaincy is often been now kind of done within the U.S. And I think that even plays out in our terminology. So it used to be called pastoral care, and in many hospitals it was departments of pastoral care, kind of coming especially out of a Christian way of thinking, Christian lingo. And a lot of that has changed to becoming more, I think, what's perceived to be more neutral and non-tradition specific. So that's where we kind of get the language of spiritual care rather than pastoral care. So there are a lot of assumptions about it, what is good spiritual care, depending on where you're coming from. So, but I'm assuming we'll probably talk some more about that too.
Yeah, absolutely. This last point about sort of how the hospitals themselves, maybe, or medical institutions frame what it is that is going on within any sort of chaplaincy department or pastoral care department, leads to, I think, a lot of ideas that people might have about what chaplaincy is. And you've alluded that it can look different in different contexts. Is it fair to say that it's one way of putting it would be it's a service that a hospital provides that is done by professional clergy people for the well-being or for the benefit of patients and their families. Is that how you would put it, or is there more to it than that? Possibly is that a fair description? And I'll direct this to anybody who's
I'd say it's pretty fair. It's mostly fair, if I could say that. I think one component that chaplains like to lift up is the staff support piece as well.
Mm-hmm.
And given especially what's going on, I think a lot of the things that you named in the beginning, Travis, all the existential weight, I think everybody's carrying the anxiety, the suffering, as you named it, I think is all too real. And I get to do I lead, for example, a facilitated group expressive writing session with interprofessional staff. And I think most people in this group now have said, we need to do this now more than ever. And a part of what we do in it is to be kind of have a space where we kind of, it's kind of to play, be creative. And we end up writing about COVID, but somehow it's a space where we can kind of be together. So and there's certain like those one-on-one conversations when you're sitting next to a nurse or a physical therapist when you're charting, but the staff piece I want to lift up as well.
Mm-hmm.
Well, the word service to me sounds pretty clinical, providing a service, especially in my context. I see chaplaincy as developing relationships with the people that live here, because this is their home, whether they're in apartments or in the care center. And choosing a nursing home coming to a nursing home is difficult for them. The elderly have so many losses in their lives to begin with. And so it's providing support as they make that transition. And, but I also see it as a service in that I'm serving Christ and I'm his hands and feet, whether people are Christians or not. It's being a presence to them. And certainly in this COVID-19 experience, people are feeling even more losses. They're not able to see their loved ones face to face, and they're not able to go to church like they used to be able to. So it is a privilege, and I'm thankful that I'm still healthy where I can come in every day. Although we do have some barriers because we all are wearing masks now. We have to stay 6 feet apart.
Yeah. Michael, I wonder, as you answer, since I know that you've done some research on the history of some of these concepts, if you could maybe expand your answer into talking about, maybe just give us a deeper understanding about the relationship between medicine and hospitals and sort of the way that they're run now, and spiritual care or spirituality and religion more generally. Sort of what is the sort of relationship generally as you see it, and how does it fit within a historical context of the relationship between medicine and religion or spirituality?
It's a big question. I'll try to do it justice very briefly. When you think of an institution like a hospital in the United States, as well as in many other places in the world, those institutions typically have had a relationship with a particular, I'll use the language of tradition again, a particular religious tradition, informing what that institution looks like, what its mission is, who works at the institution, who's on its board of directors, all those sorts of kind of organizational, institutional manners, what its mission statement is. And at least historically, in many places in the United States, not all by any stretch, but in many hospitals and universities, they used to have a very explicit, overt religious connection, because it was religious traditions and communities that were producing those institutions. That's the background. And so those institutions had sometimes explicit, oftentimes implicit connections to particular ways of thinking about spirituality and religion, in which it would be, in which those organizations would be caring for body and soul. And as we've seen in the U.S. over time, as we've seen kind of trends of secularization, those organizations have been changing their relationship to religious organizations, and its mission have been evolving and changing, becoming more leaning towards kind of language of being human and coming out of a kind of a more of a humanist tradition than explicit over religious language. And so that's affected the organization, and the organization and how it understands and perceives itself and what it's doing ends up shaping and framing what doctors, nurses, as well as those who are affiliated with, like clergy and chaplains, what they do and how they perceive their work and how their work is framed as they engage patients and patients' families. So that history really kind of looms like a shadow over how things are done now, as we've seen the secularization process take place. And it's, I think within chaplaincy, we see the changes in which chaplains have, it used to be chaplains were authorized and paid by their denominations. So they didn't need certification from a particular chaplaincy because they were authorized by their own denominations to do pastoral care. And at least in some contexts, they were paid by their own denomination. So funding was not coming, or at least funding was partly coming from outside of the hospital as a religious organization's responsibility to care for the sick and care for their souls. So anyway, there's been a lot of shifting going on over the many decades now, in which we have chaplains in which they've been working towards becoming their own health profession, differentiating themselves from clergy, and then kind of their authorization kind of coming from a different place than from their own religious organization. It's probably a hybrid model at this point still, but many chaplains in the US as well as in Europe are really pushing towards becoming identified as their own profession, not recognized as clergy per se, but a profession within the health sciences. So that's pushed towards a need to do research and so on.
Yeah, that's very, very helpful. And it strikes me, just with our other two guests coming from the institutions that they come from, that they kind of sit on at different places on this sort of trajectory in some ways, with a Christian elder care facility and nonprofit, and then a large healthcare sort of larger institution, right, with mHealth Fairview. Paul and Kelly, I wonder if that story that Michael tells, does that ring true in your experience? And then if so, how does that sort of arrangement affect the way you do chaplaincy or spiritual care in your context?
When I was in residency, which wasn't that long, well, it was 15 years ago or so, my spiritual care residency, CPE, and it seemed that it was frowned upon to offer spiritual tools like prayer for people, that some hospitals frowned upon chaplains offering to pray. It was okay if the individual requested it. And I found that to be difficult. So I felt pressure as an evangelical Christian felt stifled. We do spiritual assessments on our residents when they come in. And so we do have questions that I think are pretty typical of hospitals as well. Maybe Michael can confirm this. So there are spirituality questions, like what gives you hope? What gives you meaning and purpose in your life? And we have concerns about connections. Those are all spirituality kinds of questions. And then, because that's important, connectedness to all people. And it's a concern we have for our people right now when they're more isolated. But then we get to more specific, if they are religious, finding out more about those practices.
I appreciate you offering, Kelly, what you did. I think one of the things that you said in the beginning when you were introducing yourself is that you have this pastor role in your facility. And I don't think I have that at all in my space. I didn't say this as a part of or write this as a part of my intro. And I appreciate a comment in the Q&A from a chaplain colleague that I am myself a Lutheran pastor. I'm a part of the Evangelical Lutheran Church in America tradition, and I'm grateful for that, and I still am a pastor, but I don't wear as much of that hat. And I say as much because there are times where, in fact, this afternoon somebody has been requesting Holy Communion, and just to be, it's hermetically sealed. I know those are in high demand right now, so I'm not putting my hands on a wafer or any kind of bread, just to let folks who are listening in about that. But I do think you're right, Kelly. It's interesting to hear people talk about prayer. And I because I know kind of also have this research mantle, I find it interesting that in the National Institutes for Health, complementary modalities, the number one modality that's listed is prayer. And then there's been data out there that say that people use it as a significant part of their coping. And then I also put on my pastor hat that, in the midst of things that right now are so weighty with the suffering and the moral distress and the moral injury, I've been amazed at, for example, how there are images of nurses praying on roofs and large prayer services happening outside hospital buildings, and that this is now, I know there's like a level of how this is okay. So for me, there's like this mingling of, I think what may have been verboten in the past is sort of emerging as, hey, we are these people that have these, as Michael said, these souls that are under threat, I guess, right now.
Paul, I wonder if I could ask a follow-up on that, just partly so that people understand the terminology who are tuning in, who maybe have never encountered it before. But my next question was going to be about sort of what is our current moment bringing in terms of challenges for pastoral care, but also for care of patients and for the sort of pastoral care of caregivers. You talked about moral distress and moral injury. Could you just define those for our audience and talk about what role they play in the whole process?
And forgive me for not remembering the authors but for my sense, and Kelly and Michael, please correct, and obviously Travis, this is an area where you got a lot of specialty too. But moral distress is the sense, as I understand it, that I have a barrier or a challenge for making what I think would be a desired moral course of action. I'm a nurse in an ICU, and I feel torn about making a certain action, but given the circumstances that are around us, it makes it very hard to move forward with what would be the desired course of the action, not just for the nurse, but for the respiratory therapist, the intensivist. And then I think additionally, moral injury, which I find pretty interesting right now, because I wasn't sure prior to COVID, there's been conversation about, especially among the physician crowd, are people experiencing moral injury? And I think now that's so clear, because one of the definitions I like, it doesn't involve combat, but that we're facing unprecedented traumatic events right now in history. And we're squarely there. And people, again, your specialty, Travis, having to make these hard goals of care decisions almost unilaterally for people. And I think that weighs heavily on people, especially in our country where we, strive to have this autonomous self, and it's getting muddy and hard. And I think that weighs on the souls. Is that fair?
Yeah. Well, I'd love to have Michael and Kelly expand on that. But also, we just had a conversation on pandemic ethics and Christian ethics with a couple ethicists from the medical and public health sides. And that was something we talked about in that context, especially in light of the allocation of scarce medical resources and the tragic challenges that are being faced right now in places like New York City, but will be potentially faced in other places. The sense of the lasting impact of not being able to do all that you can do or would otherwise be able to do, and having to make hard choices that aren't immediately clearly morally right, but maybe the best you can come up with in the situation. And that's a really hard thing to have to go through for anybody. Michael and Kelly, do you have other sort of thoughts on the where else our current pandemic is pressing particular challenges of spiritual care?
I think the social isolation is a concern that I have. Fortunately, we do have resources like computers, iPads, and phones where people can connect with their loved ones, and I think that that's helping. I think for people, especially the elderly widows and widowers who are alone by themselves, and I have concerns for them, for the social isolation. And I think boredom is another concern that people have, and I've heard that alcohol use is increasing. And I have been concerned that possibly mental health concerns, that possibly depression would be going up, but so far that has not been the case here in our facility, but I wonder in the larger population if it is. Well,
Kelly, have you, sorry to
Go
just
ahead.
ask a quick question there. Have you had to restrict entry into your facility by visitors and,
Oh,
and
yes.
family members?
Absolutely. And this is something that is really hard for us because loved ones are only allowed to come if someone is actively dying. And our nurses have been good so far at calling this, and no one has come too late. But this is very hard on our residents, tenants, that they have to wait until this time, and some have fears that they won't see their loved ones again. And so this is difficult, as well as funerals are on hold. You can't put grief on hold, but we're not able to have them here at the chapel. And so I have a list of people who would like to have them at a later date. Even morticians, when they come, are not allowed to go up on the floor and bring the body down. Our staff have to do this, so this is an extra stress for them. And it's restricted. Vendors bring things to the door, so it's just staff really who are coming in, and we get our temperatures taken every morning, and we're asked certain questions, and our nursing staff's doing a fantastic job of keeping up to date. And so far, we have not, thanks be to God, have not had COVID in our buildings.
How about you, Michael?
I think what Kelly and Paul have said are really, really helpful. The only other kind of more general thoughts I would add is that I think our medical and scientific communities are being, we're seeing as a culture that they're limited. They're limited in their powers, in what they can accomplish, and which goes against part of the narrative of our culture about the strength of the sciences in healthcare, and it's exposing some of the weaknesses that were already there, but we weren't really quite willing to acknowledge. I think many in the healthcare community themselves, as doctors and nurses and others, are feeling that, or they're obviously being pushed much more to the limits. We're seeing doctors who are having to make decisions about putting themselves at risk, which is really interesting. From being from a very privileged profession that makes exorbitant amounts of money in comparison to others, now being put in positions in which they're at risk, their families are at risk. We're seeing those who are involved in a lot of medical specialties, at least in certain cities, they're starting to have to be pushed to not work in their specialties, but assist on COVID-19 wards and that sort of thing, in which you have just an extreme, like a dermatologist who has an amazing job, a privileged job, now being kind of pushed into a very different kind of environment. And so I think it's creating a lot of stress, but also exposing some of it's definitely forcing medical professionals to look in the mirror and to see that they're finite. They're not in control. They're not in control like maybe they were tempted to think. So I think that's happening. And then within the larger culture, you know, there is this whole narrative of a camouflaging of death, that we're in control, we're never going to die, we don't have to think about our mortality, our finitude. And that's been stripped away. And many of us now are you know, we're realizing there's a fundamental weakness within us. Our jobs are at stake. We don't sure if we can pay our bills next month. Will I or my family get sick? So I mean, that's kind of operating across the culture, and that is, I think, exposing, and it is creating a spiritual opportunity, in which the division of body and soul that has so framed our culture is now being challenged. Like, maybe that doesn't quite make so much sense in a pandemic. We can't think that way anymore. Yeah, just to offer those as some general thoughts.
And I think the whole toilet paper scarcity points to people they want some control over their lives, and so this is one thing that they can do to be prepared, or whatever other things they're stocking up on. It is kind of humorous in a way.
I also wanted, Kelly and Michael, thank you for your comments. One thing I wanted to add is this whole ethos I'm experiencing of this "no one dies alone" reality. And it's not just, a lot of hospital or healthcare systems have had it as a program where people would accompany those who were alone in their dying. And now for me, it's just this ethos that kind of permeates. And how that's emerged for us in our setting is they've asked us chaplains in our place if any of us are willing to attend to families in the midst of an extubation situation of those who have COVID. So there are those of us who have said, I'm willing to do it. And I think some of my own colleagues have talked about their own moral distress because of not being able to do that because of restrictions in their own lives. But wanting to be there in solidarity as a colleague, as well as with our beloved interprofessional folks that are in those spaces. And as Michael had said, are putting themselves by their own sense of fidelity to their vocation to do what they do. So I wanted to lift that up. The other thing that's been hard for me, and I don't know if this is true for you, Kelly, is or even for you, Michael, for the people that you care for that might be hospitalized, but that whole, you don't get to see when somebody might be becoming tearful, and certainly the touch, but there's all that nonverbal maybe an iPad can capture some of it, but to me, it doesn't share that sense of what a lot of us talk about as presence. If I can say one more thing, Travis, somebody had a great question on the Q&A about resources that are available for people who might not be specialists like the three of us. And there are some really good resources for healthcare, I guess as the literature calls them, generalists. And there are some chaplain colleagues, I don't know if you want me to give those to you, Travis, but there's a chaplain named Allison Kestenbaum who's done some really excellent work on this. She's out of San Diego, and then Naomi Sachs out of UCFS in California. She's put together a really nice piece. And if you have access to the American Academy of Hospice and Palliative Medicine, that was posted there recently. So
it's lovely. Yes, Paul, maybe after this call, you can send me a short list and we can get it in a follow-up email to all of our attendees who are with us so that they can see those. I want to go back to a point that Michael just made, talking about death and mortality. Many people probably know and feel in their own sort of selves that death is not something that's sort of openly talked about very often in public or in sort of polite conversation. But, at least with regard to chaplains and spiritual care providers, but also hospice and palliative care workers and doctors, I've been really struck by the way they've been able to talk about death, probably because of their experience and maybe familiarity with it in a way that's both frank and direct, but also very compassionate and human. And that's always stood out to me as a sort of very strong antithesis to our culture's allergy to thinking and talking about death and mortality and finitude. I wonder do you think that there may be something in this moment that shifts that willingness or ability to talk about death or awareness of it, or will it alter the public conversation about death and dying in any way that you foresee?
Death and dying is, we can't run away from it right now, because every day in our newspapers and on our phones or other news feeds that we get, there's the statistics of how many people have died in our cities and our state and around the world. I don't know how much people are talking about it among themselves. I mean, death is always a topic of conversation here where I work, because people are elderly and this is the last place that they think most likely they will live, and this is where they will die. So I have conversations with people regularly about that. And as chaplains, we do get a little more used to it, because I would say we have about, on average, we probably have 2 deaths a week, and not from COVID, but from other things. It's just a reality that we face here, although there are patients who come here who still deny that death is happening to them, or their family members that are in denial as well. And so that makes it more difficult at the end. But I can't really speak to the larger public so much.
Yeah, I would, it's none of, I'm not a prophet, so I'm not sure. It's clearly going to depend on the length of time that this lasts and the degree or severity and the impact that it has on us as a culture. How many people are going to lose their jobs? For how long are they going to lose their jobs? How many people will really get sick? How quickly will we come up with a vaccine? I think those are the kind of big questions that will determine our willingness as a culture to more readily kind of acknowledge and engage these big questions, and whether we're willing to take our head out of the sand and more directly as a culture confront our mortality. The more it's in our face, the more we'll have to engage it. I'm not convinced that where we are now is going to shift anything. I think people are ready to go back to the golf course and back to their jobs and and open up the bottle of champagne and forget about everything that's happened. I mean, I think that's what people are still very much longing for. And until that's broken within our culture, where we realize that's gone. We're a different kind. We're a different people. Until it's really broken, and unfortunately, it will take very severe hardship. I think in order for anything to see anything shift. So I don't wish that on us. On the one hand, I do wish it on us as a pastor, and yet I don't wish it on us at all. So who wants us to suffer in that way? So it'll be interesting to see what happens.
Yeah.
I'm struck by the images that many of us see. I'm kind of a news junkie, and the mass graves in New York to me are striking. And I don't, and this might be a little TMI, but I find myself waking of having the sense that I have this, or that I've been diagnosed with it. And there's just a part of this that I can't control, just because I'm in the milieu of it. And I'm guessing I'm not alone in that. And yet here we are, we got to plow forward in those realities. And I'm struck by the contrast, especially by people who choose to have a different approach to this crisis that we're in the middle of, and a willful disregard, I'd call it, for I think what much of the public ethos is for how it is that we are staying distance or staying at home for the common good, I guess, for the utilitarian almost benefit. And then me using words like this, Travis, is dangerous because this is your world. You've been obviously, the skilled listener here. Anyway, there's some really good questions here, so I don't know if
absolutely. Yep. No, that's so helpful. Let's go ahead and turn to our questions. We have about 20 minutes to explore some of these, and there are some really great ones. And the first one actually is for you. The first one I want to ask, Paul. You mentioned a few minutes ago an ethos about not dying alone. Somebody has asked if you could maybe say a little bit more about this concept. And I'm just going to read the question here. Is this something that medical personnel are committing to? Are chaplains still allowed face-to-face or with a mask to have presence with patients? And it says, I know some hospice homes have had to close and so also have had to end their ministry of presence. So could you say a little bit more about how not dying alone continues to be a guiding principle?
Yeah, this is a big question. Through the network that I get to be a part of, we wish we could do some research on trying to get a sense of what is happening across this country, because we do hear of healthcare chaplain colleagues who are being furloughed or who are reduced hours, and we don't know why. In some of those places, the decision is being made for that particular colleague or where they're at, and then in my own place, that there's been a different sense of keeping us around, and I'm not exactly sure why, other than I think it's part of this ethos that I'm not sure I can put a finger on. I call it this kind of no one dies alone ethic, but and perhaps Kelly or Michael or you, Travis, know more. I don't know the origins or the genesis of kind of where this movement of no one dies alone, or what some people will call NODA for short, but the fact that administration wants us as chaplains to be available for family members to support them. So at first in our setting, for example, there was a concern whether we'd have enough PPE for a family member. And it's been determined that, yes, like Kelly was saying, we have restrictions, that there'd be one person available. And it's a very tight protocol, so that with all the fully done PPE, that there would be a chance to go in if desired, or if me going in, holding an iPad for a family member at an appropriate distance. So there's very rigid kind of protocols to keep us safe while still striving to have this sense of a shared humanity. For those of us who are Christians, like this profound sense that, we share each other's burdens, that we're there to I guess, weep with one another. And then very strict on the other side, that nobody's present for the extubation, but that we would go back in, again, fully prepared for that time. I don't know if that answered it. That was some of my wonderings.
Yeah, go ahead,
I have
Kelly.
something to say. At this very moment, the other chaplain who works here is sitting with one of our residents who is dying, and he was asked by the nurse to do that. And we are allowed to be with them wearing a mask, keeping, if someone's dying though, you kind of think, shouldn't you be able to touch them and that sort of thing. She probably will die today. We are fortunate in that and this is one of the things that gives me hope or heartens me, is the number of people who are sewing these cloth masks. And so all of our staff, we are able to get a new one every day. Volunteers are dropping off bags full of these cloth masks. And so that is what I am wearing. Our direct care staff are wearing the clinical masks, but we too have a concern about how much PPE will last and that sort of thing. But I am thankful, as long as I am healthy, the chaplain and other chaplain, we are able to sit with people when they're dying, so hopefully they won't die alone. That is something we have tried to do here at our facility, and often family members, they used to be able to be here and to be present, and they still are at the very end, so a person doesn't die alone. I used to have volunteers called comfort volunteers that were trained, and they would come and sit with the dying people at our facility if family members were not able to be here. Sometimes it is impossible, though, if it happens during the middle of the night, but they are checked on regularly by our staff.
Yeah, that's very helpful. Yeah, I mean, the principle goes way back to Dame Cicely Saunders and the creation of hospice, in the very beginning, that no one should die alone or in pain, was one of her, central principles. And I'm glad to see that we're still striving to do that. That does strike, I think, a lot of us as maybe one of the most fearful elements of this disease and the pandemic situation, is the way in which it restricts movement. And for those who have it or are dying of COVID-19, dying itself is scary enough, but the prospect of having to be isolated socially from those you love and care about is an added sort of element here. Some of the questions we're getting, a number of them have to do basically with what non-specialists can do in this area. A lot of people, I know, Paul, you mentioned that you're going to send out some resources for that, but I wonder if maybe opening it up to Kelly and Michael or Paul, just there's any other thoughts that you have on this. One person has asked, what can non-experts do to provide spiritual care for those in their lives who are suffering in the midst of the pandemic? Are there any best practices from within chaplaincy or from within your own ministry that are translatable outside of that context? And then another question is basically about the question about presence. Given the restricted movement, what are ways that people can be present with those who are suffering or present to them? I'd be curious to invite your thoughts on those.
I can give a thought or two. I think chaplains and clergy have very particular giftings and training that are essential in caring for souls. But it's not exclusively given over to them as a domain that only they can operate in, and I think there's a danger of thinking of spiritual care as a specialty. And I'd want to push back on that to a certain degree, in that anyone can do spiritual care. I would argue that anyone who, from the Christian tradition, anyone who has a relationship with God is obligated to provide spiritual care in a generous, caring, tailored way to the person in front of them. And I think one of my worries about language that makes spiritual care into a specialty is that doctors and nurses will regulate that kind of work that's the chaplain's work. And I think one of the things we're seeing with the effects of the pandemic is that a lot of chaplains, they don't have access to patients at this point. And it's only doctors and nurses who are even able to go into certain rooms. And they're the ones who can or could actually show presence, and who could provide spiritual care, especially if they have some, even a little bit of training. And I have wondered whether our current context kind of exposes that rift that can come from specialization sorts of thinking, and whether we need to again invite doctors and nurses to be spiritual generalists, as it sometimes is the language that's sometimes called would be used. That they need to recognize that it's their obligation, it's their moral and spiritual obligation to care for the sick, not only physically but also to address questions of the soul. And I think the first way to do it is you just simply ask questions. It's the easiest thing to do, in which you can ask very general questions. How are you doing today? What have you been feeling? Are you worried? Are you afraid? To more specific kinds of questions. Are you, there's different ways of framing it, but you can ask questions about how's your soul. I mean, that might be a kind of a simple way of asking it. So I would really love to see our doctors and nurses stepping up and doing that kind of work. Even just beginning a conversation with the question will go a long way.
I would just like to make a few suggestions. Because anybody can make a phone call or write a note, and children can color pictures. there is one woman who lives here, and she has been so tickled by a letter she got from a 9-year-old girl. And she keeps talking about it she's sharing the contents of the letter with all of us, and it has meant so much to her. So I think people still need that connection with others, and to be remembered, that they're not forgotten, and just words of cheer anybody could do. So that's one suggestion I have.
Yeah, that's great. Paul, do you have anything to offer along these lines?
I think the world of palliative care, there's some people like Ira Byrok that I think they do a nice job of helping, I think, lay out can often be a very complex exchange between people, and how does trust get established, and with others that gets done quicker sometimes. But I think one of the questions that I love seeing passed over the years is what matters most to a person at that moment, at that time. And if it is that it is their faith, and that's something that's shared, then that, my guess is, will emerge, and it'll have that sense of being flourished, and hopefully being held and comforted, and giving us that sense of hope for the future.
Yeah. So one of the questions here that I'm seeing is basically, I think, a question about what makes spiritual care special or unique. The question is, what is the role of a chaplain during this pandemic that is distinct from a Christian social worker who's comfortable praying with clients? Does anybody have a way of talking about that sort of difference between chaplaincy and, some of these things that can be done by others? I think this kind of presses into this point we just made a little bit.
As a Christian chaplain, I can bring communion to people. That's something it depends on how your view of communion, though, and that's something that we can do that maybe the social worker can't do.
Yeah. Go ahead, Paul.
Yeah, I won't belabor this. Kelly mentioned this thing that many of us who go into chaplaincy experience something called clinical pastoral education. There's a different formation, and I won't belabor that, but I know that that's a distinct difference. The thing that for me that might be is to maybe pull in some of what Michael was saying, that we as chaplains, we are a limited resource. That's one more vantage point to bring to it. But I do want to lift up the vocation and the calling that any person brings to that. The other thing I want to point out is it sometimes just matters to the patient or the family or the staff who's doing that care, that they want to see a chaplain. Is often what I've experienced throughout my years of experience doing this.
Yeah, that's great. Very helpful. So one of sort of to conclude, I have one final question, and I was thinking about this conversation that we were going to have, and I was thinking about the role of chaplains and others sometimes in sort of not only bringing their presence into a situation of suffering and having that ministry of presence, but also bringing hope to those who need hope when it's available. But I was also just thinking about you all in your particular roles. Is there anything that is bringing you hope in the midst of this pandemic? And for those of us, who are watching or who are following along, who maybe need a word of hope or an example of where hope is being found at this time, anything that you'd be willing to share?
There is some hope. I see hope in how people are pulling together. And like I mentioned earlier, making these masks or applauding healthcare workers or grocery workers. People are appreciating those who are on the front lines and putting themselves at risk. So I see some hopeful things in human beings happening. Ultimately, my hope is in God and in the resurrection. No matter what happens to me, I know that ultimately we'll get through this somehow, and I can trust in God's plans.
Yeah, I would agree with Kelly's last words, especially. My hope is in resurrection. We just celebrated Easter, and something I said to my congregation is, I know we're all feeling fearful and afraid, but what's the worst thing that can happen to us? The worst thing that can happen to a Christian is he or she can die, and to die is to be present with the Lord. So that's not a bad thing. It's not what we seek, or we're not seeking any kind of martyrdom or whatever. But I think that kind of keeping that in the forefront of our minds at this time, I personally find really helpful. That's the worst thing that could possibly happen to me. And as I think about spiritual care and dying alone, I just put my pastor hat on for a second, and just forgive me for saying this, but I think the greatest evil is not dying alone without a person around you. The greatest evil is dying alone without God. And that's why spiritual care is so important. It's caring for souls and shepherding that soul in relationship with God, and to not so I'll just leave it at that, where that's where our greatest, as a Christian, that's where the greatest hope comes from. And I think that's what really separates the work of spiritual care as a chaplain from a social worker. It's that authority that one has as one called, at least within the Christian tradition, as one called to be a pastor to souls. Social workers, they can do that if they fall within the same kind of tradition, but they're trained not to do that sort of thing. Leave it at that.
Yeah.
It won't surprise anybody that I read a daily Bonhoeffer book, being a Lutheran, but there was a recent thing that really struck me because of our context. And one of the things that he was trying to lift up is we're future people as Christians. And as the book of Romans has, chapter 5, hope does not disappoint us. So in that shared hope that we all have talked about.
Yeah. Well, I've found this a hopeful conversation with each of you, and I know that I've learned a lot about what's involved in chaplaincy and spiritual care, and also what our current moment is allowing us to do and not do. But I am getting the sense that the important work of care of souls continues on, and the important work of the ministry of presence is continuing on in this moment despite the challenges, and that's something that I find hopeful to know as well. So with that, I do want to thank each of you, Michael, Paul, and Kelly, for joining us for this conversation and for lending us your experience and your expertise. And I also want to let the audience members or attendees know that we are going to be sending up a follow-up email with some resources for you, and we'll also go ahead and put in the chat function here links to a couple of our upcoming events. These are online forums similar to the one we're currently doing. One is on St. Anselm on knowing and believing, the relationship between faith and knowledge, and another one is on basically thinking about Christian renewal and Christian faith in the context of the public university, which is, of course, our context here at the University of Minnesota. And so I hope you can click on those and get more information and join us for them. If you want to learn more about Anselm House, please go to anselmhouse.org or email hello@anselmhouse.org. Thank you, everyone, for your time. Thank you to our guests.
Thanks, Travis.
Thanks, everyone.
Thanks, Kelly.
Thank you, Travis.
Thank you, Paul.
Great to meet you, Paul.
Thank you. Thanks.
Thanks, everyone.